Hello and welcome to the second episode of our brand new podcast, the pIBD Digest. I'm your host, Dr. Tracy Coelho, Paediatric Gastroenterologist, joining from Southampton, UK. And I have my very dedicated co-host, Dr. Chris Bakewell, who is live from Newcastle. Hi, Chris. How are you doing?
Very well, thank you. I'm not sure it counts as live technically, but if that makes it more exciting, I'm very happy to go live. Feel like a correspondent or something. I'm very pleased to be back doing another podcast after episode 1. I think it's been pretty well received. Certainly a few people at the meeting have definitely listened to it. So I'm already starting to think of the ideas going forward, what we can do. Very excited to record another one with our guest today.
That's really wonderful. So Chris is chilling out at the BSPGHAN Annual Conference, the British Society of Paediatric Gastroenterology, Hepatology and Nutrition. Chris, very lucky. So how's it going over there and how's Newcastle treating you?
If you'd have asked me yesterday, it was very cold. I did not know it got this cold in Newcastle and I didn't bring a warm enough jacket. But today it's beautiful. You call it sunny Southampton if you didn't know any better. But I guess it's worth for anyone listening to the podcast who's not necessarily in this circle. The meeting is the British Society of Paediatric Gastroenterology and Hepatology. It's our annual event to catch up, network, socialise and hear some state-of-the-art lectures and otherwise. So really nice to meet people again. You know, often you haven't seen people for the whole year. And so far, I think, you know, we've had 2 days and some absolutely fantastic talks.
So I imagine you're gearing up for the gala dinner. Some good food, few drinks, and maybe even showing off some groovy moves on the dance floor.
My ability to embarrass myself on the dance floor knows no limits. I will be hoping that no one records any videos, but we're also recording a podcast tomorrow morning, all things going well, so I'll definitely be on my best behavior.
So Chris, I think I should resist the temptation to ask you about the food, the conference setup, because I don't want to offend the organizers. But hey, you can answer at your own risk.
No, the setup's been brilliant. We're in a very plush hotel. Food's been lovely. I think the whole environment's been really sort of planned out very well. David Campbell, who is the incoming president, has done a really good job. And I'm sure there's lots of people behind the scenes making it a good meeting. But, you know, year on year, I'm always very impressed. I'm very anxious that Southampton's been chosen for a meeting in 2 years' time, but I'm sure we'll find a nice hotel somewhere.
That's really exciting news. Chris, you are not easily impressed. So the conference must have been truly outstanding for you to be impressed. So I reckon we should have a good old juicy chit-chat tomorrow with James for the next podcast. I'm fully aware of this spectacular evening that you've got lined up. So I won't keep you gabbing too much. So you and our special guest, who is also at the venue for BSPGHAN, will be getting late for the evening. So no more dilly-dallying, I'll dive straight in. Well, today's guest is a big deal. She is a powerhouse in pediatric IBDology, the UK's very own queen of BSPGHAN's IBD working group. I'm sure she would prefer the term chair of the IBD working group rather than the queen, but certainly a powerful voice to be reckoned with. She's also a very dear friend of mine. Therefore, I think we got to be on our best behavior. Would you, Christopher?
It's difficult to know what to say next after that sentiment. Certainly glowing and absolutely deserved, I'm sure, but I can't add too much to that, so I'll keep my mouth shut.
Okay, so without further ado, and before Chris interrupts me with another question, let me roll out the virtual red carpet for our phenomenal guest this evening. A brilliant mind, a fantastic ex-colleague, and an all-round GI superstar, Dr. Anthi Thangarajah. Hello, Anthi. Welcome to the pIBD Digest. Thank you for joining despite such a busy day and evening.
thank you, Tracy and Chris, for that really lovely introduction. And thank you for asking me to be on the second sort of outing of the pIBD Digest. I'm truly honoured.
Thank you. So, Anthi, I hope my introduction has done justice to your brilliant profile. If not, I would be more than happy to add a bit more flair and drum roll.
No, it's very glowing and it's very kind.
That's not an insincere thing. He will give you a drum roll if you want one. So, please do say at any point.
No. I know Tracy very well.
Anthi, as you know, for our very first podcast last week, we had grand plans to give James a proper Maharaja's welcome. That, of course, didn't happen. I was at least hoping that Chris, in a last-minute act of redemption, would manage to source a garland or a bouquet from Newcastle for you. Wishful thinking.
Well, but you gave me a Maharani welcome.
Maharani,
Tracy.
oh yes.
Is that what a female Maharaja is? A Maharani? A queen? Oh, okay. Shamedly, I did have to Google Maharaja to make sure I knew what it was. And I would also perhaps like to move slightly away from Maharaja or Maharani for this podcast. We've had very good feedback, but a lot of the comments have been about Maharajas. So it's not that Anthi doesn't deserve all of those accolades and all of those, garlands and things like that.
Oh no, I know.
I think getting back to the reason why we're doing it, because we do have a gala dinner, and also the people listening probably don't want to hear too much of me or Tracy talking. I didn't realize I was excited about podcasts until we started doing one, and then I thought actually it's quite fun. And I think the idea of a sort of hot off the press podcast from BSPGHAN felt really, really good. And so we sat down and looked at the timetable and picked out your talk, Anthi, as something that really would be hugely relevant to the people listening. It's really perfect for the audience, and I'm really excited to hear you talk.
Thank you very much.
Thank you. So, Anthi, a fly on the wall has it that Chris has been furiously taking down notes during your presentation. So before he starts firing off all questions left and right, I just wanted to take a moment to thank you for your incredible support for the podcast. I must say you are a total legend in supporting us.
It's very kind. No, I think it's a really exciting initiative, and we need to move with the times. And Tracy, as you know, I'm an avid podcast listener. I will not advertise the one that we both listen to. So I think it's a great way to diversify education and learning.
Anthi, you'll be surprised to know that Chris has also been a keen listener of that podcast at one point. And now that you mention it, actually I was planning to talk about it. But sadly, Chris decided to exit.
Yeah, I'll consider myself the editor of the Chit Chat.
Yeah, no, it's fine.
Okay, Anthi, before we dive into the fascinating world of advanced therapies in IBD, how about you give us a little peek into the person behind the expertise? Well, tell us about your professional journey, maybe even share a bit of your family background if you're up for it.
Okay, no, absolutely. So I trained at King's College Medical School, and very early on, actually, I knew I wanted to do paediatrics. So weirdly, my paediatric attachment is an extra, and that sealed the deal. I knew paediatrics was for me. So very sort of after graduating, I went on to a paediatric rotation at Barts in London, and from there, that was my first exposure to paediatric gastroenterology with Nigel Meadows, Sandy and Ike, and the team at that time. And from there, I went on to apply for the grid application in pediatric GI, and I was awarded the London number. So my pediatric GI experience is based majority in London. I've had a very rich and varied experience. Amazing mentors and supervisors. I have to give a shout out for Dr. John Fell, because he was my PhD supervisor, as well as really key to as a key mentor for my training. And I will miss him because he's going to retire probably towards the end of this year. So he's a big influence in my practice and in my professional career. From a personal point of view, so I'm quite a busy person. I have 3 children. We have a sort of trying to coordinate things as slightly like a sort of, very coordinated and rigmarole type aspect between my husband and myself, both being medics. But they are great. They do often laugh that, "Mummy, why are you a poo doctor?" That's their why that one, Mummy? And, they think, well, why can't we talk about poo now? And it's really quite interesting. We have a lot of laughs about that. But no. And actually, my daughter's pursuing the medical career and is currently a student at Imperial. So there you go.
How nice. Your husband, remind me, is not a poo doctor. He is a bone doctor. Is that correct?
He's not really a doctor. He's an orthopedic surgeon. Sorry to any orthopedic surgeons listening out there.
Oh, we may have to edit that one. But
No, that's fair, and I think we should keep that. So, Anthi, because Chris is getting a bit restless, unfortunately, I could not attend the conference as I was holding down the fort here in Southampton. Now, could you share a summary of the key messages or the key takeaways from the talk?
So I think initially I was given the title as Advanced Therapies in Paediatric IBD, and I had to change it because actually, if we're going to talk about advanced therapies with evidence-based RCT trials, there aren't any, essentially. And I think we have to be completely transparent about that. So the talk really was looking at the advanced therapies that are available in IBD, what's been effective, what isn't effective, and just trying to overview those. So essentially there was a lot of classes to get through, but I focused on the new anti-TNFs, the IL-23, the study designs which have essentially gone to the head-to-heads, as well as sort of the advancements and other possible targets in the future. And I think what's quite exciting is anti-TNFs we are all very familiar with, and sort of the advancements in that area with subcutaneous infliximab, as well as not quite there in IBD, but the possibility of small molecule monoclonal anti-TNFs, which I think is really exciting. And then just thinking about the head-to-head studies, particularly with the IL-23 agents, so particularly risankizumab and mirikizumab versus ustekinumab. So those are the studies that were just presented at ECHO, showing superiority to ustekinumab for both versus risankizumab as well as mirikizumab. And just one more thing, I did also touch on combination treatment and novel therapeutic targets, but really for me the take-home messages are, okay, we have all of these drugs available, but they're all off license, they're unlicensed in pediatric use. And the basis of this talk isn't saying go and use all of these drugs. No, this is the data that's in adults, and we have to be responsible, I think, as pIBDologists to think, look, we don't have the safety data. It's 2 or 3 year follow-up data, and you have to really think about when you use these drugs, or if you feel that you have to use these drugs, most likely in refractory patients.
Thank you for that summary. That is literally the perfect thing you could have said, because I think that picks up on the exact reason why we wanted to talk to you. Because when, obviously Tracy didn't get the benefit of hearing your talk, but when I was sat there, it's amazing that there are so many new therapies, and it's really easy to get really excited about what might be on the horizon. I guess specifically in pediatrics, you touched on the evidence is always going to be quite low in big head-to-head studies and trials. We're going to have to use adult data. And it's always really tempting to see new therapies as a sort of panacea, a paradigm shift in how we're going to treat IBD. But if you look at, from the first trials 25 or so years ago and our first use of infliximab in adults, none of these new therapies have really been revolutionary. They've all incrementally changed what we do, and they've given us more resources to use, and maybe even over time become a bit more sensible about how we use them. But even so, you talked about that therapeutic ceiling, this kind of 30-40% efficacy in all of the drugs, even if you try and optimize them in a clinical trial where those patients are adults and selected really in a very specific way. So that maybe doesn't even translate to real world. In terms of your strategy, so say, for example, a common scenario, a child with maybe Crohn's disease who's started on an anti-TNF and either flared early or has flared into their disease, or they maybe haven't had a complete resolution. Do you have an overall strategy of how you would do it? And I guess what I'm asking is it's the optimizing anti-TNF as the most evidence treatment versus when to switch? Is there a kind of strategy in your mind, something you'd adopt?
So one of the things that we are very proactive in our unit, and I'm sure you probably reflect the same practice, is sort of proactively monitoring our patients, and picking these aspects where is your target achieved. So just going back to the STRIDE 2 criteria and treat to target. So you have outcomes that you're constantly assessing and identifying those patients early. But I would probably even go back as far as even prior to starting anti-TNF in terms of risk stratifying that patient. Are they a high-risk patient? So, for example, if it's Crohn's disease, there is, in the current guidelines, you can stratify your patient to your high risk or moderate risk. And those patients, you're going to start treatment early. You're probably going to start a biologic early with an anti-TNF. And the second thing is to think about the induction phase. So we do have a proportion of patients that even during the induction phase, the clinical response is not adequate enough. And in those patients, when you're intensifying them early, you already are planning. You're not waiting to say, okay, if this doesn't work, then I'm going to try that. So that's sort of just the preamble. But then if you say, I always like to think, have I got a primary non-responder or a secondary non-responder? Have I had a partial response to anti-TNF or not? Whether or not do we intensify or do we reinduct? So particularly in our unit, we are very, so the two scenarios. If you have your patient that's not responding or there's no clinical response within remission, we may get an early induction level at dose 3 to understand, okay, is this possibly a primary non-responder, or we're just not getting adequate levels? Does that make sense? So that's one strategy. The second strategy is if this is a patient who loses response, a secondary non-responder, okay, is that due to trough levels or is that due to just a true loss of response? Now, I did touch on this in the talk, but when they looked at adults versus pediatrics, the loss of response in pediatrics was not to do with anti-drug antibodies or low trough levels, because we're all quite good at managing that. So there is a little bit of an unmet need there in pediatrics because we're different to adult practice. And the speaker who followed on from me gave a really nice talk where they're now in their UC guideline, for example, are talking about giving 10 per kilo to UC. We do that quite a lot of us do that already, which is now going to come into the new, most likely the new pediatric guideline. So that's those strategies, just to try and understand where you're coming. Now, one of the things that was really fascinating sort of in UEGW, which Professor Tanasi touched on, in thinking about your anti-TNF failure patients, so your primary non-responders or they've lost response, which agent should you go for? So bearing in mind, we touched on the sequence study, and I also touched on the study, the head-to-head. I mean, guzilizumab and mirikizumab is not really available in pediatrics. There's no pediatric data, but there is data for risankizumab, and it is superior to ustekinumab. But one of the things that it was quite interesting, the adults say that they wouldn't use it in a patient who's got significant small bowel disease. So my strategy would be, okay, primary or secondary response, have we optimized TDM? Provided there's no anti-drug antibodies, i.e. do you need to reinduct, do you need to get those levels back up again, then you've got to think about an advanced therapy. And it's going to be between either a JAK inhibitor versus risankizumab. Sorry, there's a rather long-winded...
No, brilliant. Loved it.
Okay, thank you. It's a fascinating insight into how your practice works anyway. So I must say we have a very similar approach in Southampton. Of course, all in accordance with the recommended guidelines. Now, Anthi, given that our paths have crossed during training, it's only natural that our approaches share some similarities, if not all. Anthi, obviously there are so many of these ABs and IBs packed into the new toolbox of monoclonals.
Tracy, can I just add something, one more thing, and just on the back of the last question? The most other important thing is when we're using these drugs off-label and off-license, I always take these patients to the adult MDT. I always take it within our departmental MDT, and particularly when they're very refractory patients to our regional complex IBD service. And for us, that is Great Ormond Street. So, we can all go to ECHO or UEGW and say, well, that sounds like a good idea, but you need other people to kind of say, well, actually, expert opinion, consensus, yes. And I think that's the other bit of it in terms of it's really important to make sure that that's clear. Sorry, just to go back.
I think that's true of lots of these clinical scenarios, even beyond IBD. Pediatrics, you just need to get as much information as you can from the people that know how to use it, because ultimately that's all you really have. You have your own experience, but if you can multiply that with people within, co-located pediatric and adult services, I think that's really helpful. It's a good point.
Yeah, I mean, there is also a limit. We've got a great relationship with our adult colleagues, and I think it's so important, and they really value that, because our patients become their patients, and we don't want to do something which is slightly out of keeping with what they would do in their practice. And we had a really great talk. The keynote speaker was Prof. Lindsay, talking about refractory Crohn's disease and how he managed it, and very much those principles we do think about it.
Yeah, I think it's a fascinating idea to have these regional MDTs. Obviously, in London, you have many more hospitals with pediatric GI centers, and it's a great idea to discuss refractory patients and how best to take treatment forward. So, Anthi, as I was mentioning, there are so many of these new advanced therapies in our armamentarium. Now, if I could pick up two of those, for example, in our setup, we have been using JAK1 inhibitor, upadacitinib, and also recently there's a lot of talk and I haven't used it myself, but my colleagues have been using risankizumab. So what's the evidence in children, and what's your experience in your hospital?
So there's number one, there's no RCT trials in children for both of those drugs. We can just be completely upfront, and a lot of the data are retrospective, small cohort data of heterogeneous patients. Okay, so for both drugs. So I think the RISA-KIDS preliminary report on about 25 patients showed that there was efficacy in patients who've got Crohn's disease with refractory disease, and they looked at their primary endpoint being steroid-free remission. And they did show that there was a good response. But I mean, I'm going to play slightly devil's advocate, because these are all 5, 6, 20 patients. Basically, as I said, there's no RCT trials for either of those drugs, and they're just small cohort case series. And majority of those have been in Crohn's disease and pediatrics. Although the data supports upadacitinib use in UC and Crohn's, particularly for patients who are bio-experienced or biologic failure in adult data. And our experience is risankizumab, very low side effect profile in terms of compared to your JAK inhibitors. The rate limiting aspect is the dose is fixed. So if you've got your child under 40 kilos, it's a little bit challenging. And we do have those probably pubescent children who are under 40 kilos because they've just got really bad Crohn's. And I think that's difficult. The pen has come out, the 150 milligram dose. So I think that's a bit of a practical aspect. And the upadacitinib, we've used it in our refractory Crohn's with extensive small bowel disease. And in our unit, it's been quite transformative for these patients who've been very difficult to manage.
Yeah, I would agree with you. Even in our practice, we have had similar sort of experience. Often we use UPA at a time when surgery becomes imminent. Probably we should give it more time. So sometimes we deem UPA as failure in a given patient, but it may be because we have used it at the last minute rescue treatment. If we had to give it a bit longer, maybe it would work better.
I think that's a really good point, because I'm almost certain that people are using these drugs in very different ways to start with, and you see really good efficacy in the 2 or 3 patients you start it on. So you might become convinced that that's the patient that benefits most. Actually, you don't know, because there might be another centre that's done it in a completely different way. And I suppose opening up that conversation about learning from other centres is touches on what we talked about earlier, but it can only be a good thing, can't it?
But just going back to that, and I suppose going back to Jochen Kammermeier gave a very nice talk about bioresource, and putting all of these things together, that could we have more of a real world experience? We're however many pIBD centres in the UK, and if we all have 4 or 5 patients and you put them all together, that would be more powerful, and to understand what side effects you see, and this is what happens in practice. So that's something that...
Yeah. I think there's loads to pick up on there, really, and you could talk for a long time. I think, a lot of the themes of what you talked about, there's this excitement, but then there's the practicality of it. And one of those things, you've said about the dosing structure and some of these drugs that come in pens, and it's impossible to give lower doses, and actually should children be having those doses, or the practicalities of giving those doses in smaller people. There's also navigating a complex value-based healthcare system like the NHS, others exist as well, and how you get around, you've got a patient who you think that will benefit, but then how you get that funding in place, and it will differ in different centres, depending on what your local setup is, or the relationship you have with your funding team. You may be lucky enough to have a biologic pharmacist who can help you navigate that pathway, or you might not. And then you've got quite a disparity in what you have access to as a patient with IBD.
Absolutely.
I wonder, it's sort of a two-part question, but initially I wonder if you could maybe speak to your experience of how that is navigating that process, because you're obviously using quite a few of these very exciting new drugs, and have you had any difficulties with getting them funded or approved?
So I think there's two things. So from my own experience, we have to go through, and it depends on the drug. So when we first started using upadacitinib, we had to have a chairman's action. We had to go through the clinical governance sort of advisory, within the board, and an agreement that if NHSC did not fund the drug, that they would continue to fund the drug, because the other option would be surgery, for example. So we have to get that all in place. But of late, and I don't know whether this is true for yourselves, but because we are co-located with our adult colleagues, all of those drugs are on the pharmacy, are on the formulary. So it's not like they have to create an order to get these drugs. They're already there. And that is an advantage, because they're familiar with it. And of late, we as a unit have decided that actually we need to be very tight on consent, tight on documentation, as well as, because these are unlicensed drugs. So that's the only thing, because I don't want people to think, well, you're just going to use this drug because you can, because that your trust will pay for it. No, we do have a very measured thought process before we go through that fact. But there is a process where you have to present the evidence, present the case, particularly in the younger children. So the children who are prepubescent particularly, they're quite challenging, and again, it's quite a rigorous process.
Yeah, I mean that leads perfectly onto my next question, which is navigating that consent process, because we have to be honest, these are drugs that we don't know a lot about, and especially a lot in children, starting it early, what the additional risk factors are, and parents would be rightfully sometimes questioning how much knowledge we have about the drugs. How do you approach that consent process then with these novels?
So we're completely transparent. We'll say that there are no studies or, drug trials in children for this drug. This is the evidence. It seems to work in adults, but it's unlicensed, and we don't know what the side effect profile is. And I document it very clearly in the clinical notes, and we do an informed consent. And I'll be honest with you, I don't think I've had a parent who said, no, I don't want it. The other option is, particularly for clinicians who don't have the option that their trust would fund it, is to send the patient to a unit where a trial is ongoing, because then that is, wrapped up within that trial. And particularly for these medications, these trials are in particularly for UPA anyway.
I totally agree with that. Now, another key dimension with regards to the second or third line drugs is the cost. I suppose we need to factor that in when we consider switch of treatment in our patients.
Absolutely. The hospital, because we're using them off-label, often has to absorb the cost. So there is that aspect as well. So one of the things that we're very clear about in our unit is, we do look for an early response, because if there hasn't, and particularly with a short half-life with the JAKs, if there has not been a response, you have to make a call. Well, okay, is it right to continue on this medication if it hasn't had a good enough clinical response?
That's a very good point. Thank you. Now, just another thing. Lots of patients ask me, why on earth are all these new medications named OBS and funny names, tongue twisters. And what I say to them is that these drugs have got complex names because of the way they are named according to international guidelines.
Yeah. So the names are given to them. The drugs are named for them. The generic name is given by an organization. I don't know, is it the WHO? So it's an organization that they apply for a name and they're given that name. And obviously the MAB indicates a certain aspect of it. But it must have an algorithm to say not too many consonants and not too many vowels. But most of the time it feels like it's all consonants.
I think it's all very complex because in the name of the drug, there is so much of information, including the drug structure, source, and target.
I have to say that before I did my talk, I did have to go through all of them to make sure that you said that I said them correctly, because it's a bit of a tongue twister. You have to slow your speech down.
Great. So, Anthi, thank you very much for all these detailed insights into very advanced treatments in IBD. I'm very well aware there is a spectacular event this evening. And I know you're all super keen to get ready, dash out of the door. But trust me, they won't start until you walk in. So no more IBD questions. But I've got my poem ready. Are we good to roll?
Let's go. I'm looking forward to hearing the recital.
So as always, there's a friendly disclaimer. This poem is in no way meant to offend anyone, especially our guest. So just a few harmless verses with no ulterior motive. In this poem, I am impersonating as the thiopurine drug, overlooked, unappreciated, and almost forgotten. So here I go. The Thiopurine Exodus. For decades, slowly slipping by, until this very competitive day, no snobbish newbies have so menacingly come our way. Even in this era of incantations of monoclonal UBs, thiopurines have always had a say. In the rushed, wiser way of their own, for the evidence-piecing uppity bones, it's just the IBs and the UBs that matter, dropping in so thick and fast, in swathes of chronic clones, cancer scare or what not. Oh, things so glaringly rare, haven't you met the many happy ones, so often dodging the flare? Never been the pricey ones, lest the poorest of nations couldn't dare afford. And here they are, the costly usurpers, Upa, Tofa, and the other funny word. In these times of austerity, all you not-so-savvy commissioners, haven't you got your senses on board? Perhaps it's too easy to embrace all promising, albeit so uncharted and new. Your pardon in sincerity we seek, if our desperate recalls seem nothing but distraction to the dithering yet topical view. Never mind the time-tested wisdom that favors the ubiquitous, the devil that you always knew. Thank you.
Very nice.
Thank you.
Very good.
Thank you.
I love the rhyming couplets, I have to say.
Thanks.
There you are. Any more feedback, Anthi? I would like you to give a lot of feedback for Tracy about his poem.
No, the clap and the applause was great. Thank you. Happy with that.
It's always a joy to hear your poems about IBD drugs, Tracy.
That inspires me to continue doing it. Thank you.
Thank you very much for asking me to be on this podcast. It was a pleasure.
Oh no, I think as you've talked, I've come up with so many more questions that I wanted to ask you, and I think it's just because it's one of those topics where, well, first of all, you're very knowledgeable on it and speak very well, but also it's the fact that there are so many nuances, and the experience counts for so much. Almost the more you talk, the more things that you'll want to talk about. But I think we'll probably have to leave it there. Maybe there's another podcast episode in there.
I would be delighted to come back, particularly if you do another poem.
You have to bring a poem next time.
No, you will be invited. If you come the second time, you will get a sticker.
Oh, that's very kind. Very kind. Okay, thank you so much, gentlemen.
Thank you.
No, thank you. Dear listeners, thank you for joining. We hope you enjoyed this episode. Stay tuned for the next one coming very soon. Goodbye for now. Have a great day.